Good evening, everyone. No, that was not me singing, nor is that me you see on the screen. That would be Enya. This may sound odd coming from a millennial, but who doesn't like listening to some Enya, right? 4 times Grammy Award winner, and she lives in an Irish castle. Her hit Only Time, I think, is an ethereal piece of music. Those of you with different musical tastes may be rolling their eyes right now, maybe even hemorrhaging from the ears. Nevertheless, this track philosophizes about how only time can tell us what will happen in the future. And now, I am going to share with you all about what time has told and revealed to us about antibiotic resistance. 8 decades ago, keeping things with the Irish theme somewhat, as well as the concept of time, Scottish bacteriologist and father of microbiology, Sir Alexander Fleming, in his interview when he was the recipient of the Nobel Prize in 1945 with the New York Times, made an important statement. He said, "It is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. And the same thing has occasionally happened in the body. And by exposing his microbes to non-lethal quantities of the drug, make them resistant." So when Alexander Fleming gave the world a great gift, he also issued a warning that the misuse of penicillin could result in its resistance. And indeed, within 10 years of its wide-scale introduction, it certainly transformed the medical response to previously lethal diseases that were rendered very much treatable. However, it also transformed the bacterial species population, and misprescription and mishandling resulted in resistance that has grown. So fast forward again, when Enya released her tympanic membrane banger Only Time in 2000, something else more insidious was going on. Carbapenem-resistant Enterobacterales, CRE, were busy emerging across the USA and also on the world stage. With a mortality rate of up to 60% for bloodstream infections, they are indeed difficult to treat and often fatal. Our time with antibiotics is numbered from the day a new one is discovered. Resistance is an inevitable phenomenon. However, it is accelerated and driven by poor prescribing practices, amongst other factors. The emergence of CRE highlights the importance of effective antibiotics, as the carbapenems are our last-line agents, or at least they were, to maintain the safety of our healthcare system. Infection is the connective tissue that bridges all medical disciplines, as you can see. I believe that this topic is no longer a nice to know, but a need to know for all healthcare workers, from general practitioner to specialist level, and in allied fields. We will need to run a tight ship to meet this global, public, and private health crisis that is costing millions of dollars, pounds, rands, all currencies, and far exceeding such value in mobility and lives lost. Success is Apologies for that interruption. My journey with CRE began some 5 years ago at Tigerberg Hospital. Now, this may not be a New York Times headline, however, one not so fine morning, This was the news headlines when a CRE outbreak shook the pediatric neonatal platform at Tygerberg Hospital. I think it's ironic that the largest hospital in the Western Cape and the second largest in Southern Africa succumbed to something so small, invisible, that was able to instigate such a level of
We apologize for the technical difficulties. Please just give us a few seconds.
May I proceed, Yolandi? Are you able to hear me, everyone? Okay, I apologize for that. As I was saying, my journey with CRE began some 5 years ago at Tygerberg Hospital. And it may not be a New York Times headline, however, one not so fine morning, this was the news headline when a CRE outbreak shook the neonatal platform at Tygerberg Hospital. I found it ironic that something so small and invisible was able to instigate the level of disruption that it did to normal work as usual, inciting much fear and being responsible for the sad headline that you saw on the previous slide. But out of sight, out of mind, right? We generally tend not to think about melting ice caps with the energy and water crises that's facing the world unless we are directly impacted by the consequences. But rest assured, we are all now being directly confronted with increasing CRE prevalence at our facilities. I'm sure that is the reason why you joined the call to learn more, because the rate will not diminish or cease unless we change our approaches to our medical practice. So this is definitely a subject that needs your attention and swift action. So I'd like to share a quote with you and that I'm sure many of you can resonate with. So Sir Isaac Newton said, "If I have seen further, it is by standing on the shoulders of giants." And indeed, at my time at Tygerberg Hospital, I had the pleasure of working with the pediatric ID head, Prof. Helena Rabi, whose clinical experience precedes her. There's also Prof. Audrey Becker, who is the head of neonatology, and last but not least, Prof. Angela Jamoski, general unit head, also neonatologist, ID specialist, and infection preventionist recognized by the Society for Healthcare Epidemiology of America, as well as the US National Institute of Health. I worked with this team on stewardship rounds and also to identify this outbreak and contribute towards its containment by being a part of the outbreak response team. So this Tygerberg Hospital sees 8,000 high-risk obstetric births annually and 3,000 neonatal admissions. Even though it all started with just 1 or 2 babies in a very short space of time, within 2 weeks in fact, we found 1/3 of the entire neonatal platform exposed to a case or a contact of CRE. And just reflect on those numbers I shared before of how busy it is here. So what had to happen? Entire wards had to be closed to admission, and a total revision of inter-ward patient flow had to be instituted in the form of cohorting. New wards had to open, a big ask for a resource-constrained facility. in an effort to curtail the spread of CRE and avert escalation of what was already a crisis. High-level contact precautions were engaged across the neonatal and pediatric platforms. Enhanced screening, surveillance, antimicrobial stewardship, staff education, weekly management meetings, and enhanced environmental cleaning was the order of the day that saved the day. CRE at that point was a once-in-a-blue-moon phenomenon. It was a rarity to encounter maybe once every few months. However, from that point onwards, we all watched, my colleagues and I in microbiology, and how the numbers grew and grew, daily, weekly, and monthly, until it became endemic in the institution. And in fact, this, I'm sure, is echoed at many such institutions, and you can relate to this. So I was involved in educating my own and sister departments, as well as staff at Red Cross Children's Hospital, where some of our babies were transferred to. Let the role of education in an outbreak and beyond never be undervalued. Think at how ignorance on any subject can take many far down the rabbit hole of confusion and error. Proper insight and knowing can empower right action, order, and balance, which is my goal for this evening with you all. So, the ABC of CRE, not the PhD of CRE. Like many topics in medicine, CRE is of limitless depth, and I don't want to overwhelm or Cinderella you into a microbiologist by midnight. My intention here is to equip you all with practical knowledge, context, and personal insight into simplifying what can be a very complicated subject. I hope to leave you inspired and empowered to contribute to your local CRE responses. So, antimicrobial resistance, as we all know, is one of the biggest threats to global health, but also food security. Can you hear Gordon Ramsay minding his P's and Q's at the top? It also threatens every aspect of development today. In certain countries, antibiotics, their use in animals are 4 times or more than that in humans. They're used for growth promotion and also disease prevention, but that contributes to AMR. Antimicrobial resistance can affect anyone of any age and in any country. It occurs naturally, as I mentioned, and as Alexander Fleming warned, but its misuse, the misuse of antibiotics in humans and animals, so this is a One Health issue, is accelerating the process. So I would like to zoom out now. A growing number of infections, not only the Enterobacterales, but tuberculosis, gonorrhea, salmonellosis, are becoming harder and harder to treat as AMR becomes more rampant. And of course, new drugs are quite dry in the pipeline. So if you look at the slide, the WHO has a global priority pathogen list, and I have circled here where the Enterobacterales fall in this. So you all would be familiar of species like Klebsiella or E. coli. And I think it's important to know that this is where we are focusing, and that organisms like Acinetobacter and Pseudomonas do not constitute the carbapenem-resistant Enterobacterales. So, the Enterobacterales, where are they? What are they? By and large, they are normal inhabitants of the human and animal gut. They, again, under normal circumstances, they aid us by assisting with things like food digestion, nutrient production like vitamin K, and preventing other pathogenic organisms from taking over and causing disease. C. diff would be an example. However, in certain patient profiles and when things go wrong, example, a ruptured appendix, the Enterobacterales too can cause illness. So at the bottom right, I just put a picture of a gram stain. So regardless of species, they all appear that way to us in the laboratory through microscopy. So to give you more clarity, tomato, Enterobacterialis, Enterobacteriaceae, what is the difference? Enterobacterialis is the order. This order has 7 families within it. And in these families, one of them is Enterobacteriaceae. Not to go too microbiologist on you, I think it's just important to know that several bacterial species are clinically significant as pathogens, and this is where CRE fits in. Examples would be Klebsiella, Enterobacter, Citrobacter. There are actually 33, I believe, genera in the Enterobacteriaceae family. So now I want to take you into a little bit of a history lesson. And before you fall asleep on me, appreciate why this is important. Have you ever been to a meeting, an AMS meeting at work, wherever it is, and you found yourself repeating patterns that you were hoping to perhaps overcome maybe a week ago, a month ago, a year ago? This is a theme of life, and this is where history has value. So let's go for it. Now, while we were all concerned with the big hair don't care attitude in the 80s, look at that structure, that chemical compound. It is the carbapenem structure. They came onto the scene in the 80s. And I bet that when they came on, if you can see those 2 bacteria next to those 2 ladies, they probably got a fright, because if bacteria had hair, it would be their pili. And when they saw the carbapenems, I'll tell you why they were afraid. Developed in the 80s, a thianomycin derivative, imipenem and meropenem were its first members. They had broad-spectrum antimicrobial activity, including cover of Pseudomonas aeruginosa, positing them as excellent nosocomial cover. And back then, nearly all Enterobacteriales were susceptible. So it was game over for them if you hooked one of these out. So let's progress a decade later, when the Spice Girls came on the scene, and also the movie Ghost. So again, I put a chemical structure on the screen. I wonder how many of you know that. If you do, you can put it in the chat. But I think Whoopi Goldberg's warning of danger was not just to Molly, because that structure I showed you, they were the cephalosporins. And at this time, the 90s, development of resistance to cephalosporins started to become more and more prevalent. And until then, they were the first-line agents for the Enterobacteriales. And why was resistance becoming more prevalent? Because of ESBL acquisition. If you noticed in my title slide, I said the ABC of CRE. CRE is the new ESBL, and you'll understand why in a bit. So ESBLs, they inactivate their enzymes that hydrolyze penicillins and first-generation cephalosporins, and also, for all intents and purposes, third and fourth generation cephalosporins and Astroneum. So what happened then? Of course, it wasn't become so safe to use them as much, and their use decreased. And what did we resort to instead? The carbapenems. So pivotal international studies demonstrated how Klebsiella ESBL strains had better outcomes with carbapenems versus cephalosporins or fluoroquinolones. So since we're correlating AMR throughout the decades with world events, in 2000, we saw the mapping of the human genome. But microbiologists were busy welcoming a terpenem onto the scene. So, shiny new car, you want to use it. Prolonged half-life, very protein-bound. very good for just a single day dosing compared to its predecessors. And this set it up for excellent for use in community dwellers. And so what did we see then? Over a 4-year period, carbapenem use increasing more by 59% in a sample of 35 university hospitals in the US. So, in the early 2000s, carbapenem resistance in Klebsiella and other Enterobacterales was rare in North America, just as it was at our institution. But, of course, there's always a but. Okay, I haven't been here, but it's on my bucket list. New York, right. So I'm sure you can hear Alicia Keys if you're familiar with the song, but something she doesn't sing about. Not only is it a concrete jungle where dreams are made of, in fact, CREs are made there too. Why do I say this? Because at that time, in the northeast of the US, there were many outbreaks, particularly in New York City, and it contributed to the rampant spread of CRE to almost every state thereafter. So things started in North Carolina, which I'll explain, and it checked on. And this is all because of how CRE works and what it's doing locally and under our own institutions' roofs as well. So come 2009 and 2010, the National Healthcare Safety Network from the CDC informs us 12.8% of Klebs pneumo isolates associated with bloodstream infections are CRE. And we all know about bloodstream infections. We cannot afford to waste time with our empiric antibiotics. The more you delay appropriate therapy, the higher the already high mortality is. And we all know how difficult it is to empirically cover for CRE. So, in 2012 and 2013, the CDC reported that CRE increased. Remember, it was also quite rare, but it had increased fourfold, extending to 42 states. And why is this? Increased carbapenem use, as it was clearly shown. Antibiotic misuse. But there were other factors too, IPC related, as we will unpack. And also travel patterns are very important. And just for dramatic effect, it's ironic that this correlated with the end of the Mayan calendar, or the so-called doomsday in 2012. So, carbapenems, the crux of it all. In 1996, the sentinel CRE Klebs pneumoniae, North Carolina, which I showed you on that map, was called KPC1. So molecular typing was done on this enzyme, and I will inform you of the value of that, especially in epidemiological tracking and outbreak containment. So KPC is the name of an enzyme. As more outbreaks were identified, their molecular fingerprints were unpacked. So KPC2, or what we thought was KPC2, was found in Baltimore. However, later it was shown to be identical to KPC1. So this is showing the efficacy of CRE to spread across states. So then we had KPC in New York City, and now KPC is very much endemic throughout the Mediterranean basin, Israel, Greece, Italy, SA, China, Australia. Intercontinental transfer, that is what this is capable of, CRE. So also the index patient with KPC Klebs pneumo from Mendelen, Colombia, was actually from Israel. He went there for a liver transplant. And Klebs pneumo from France and Israel were also shown to be epigenetically linked to the predominant strain in the US. And we all know the world is a global village now, right, with travel. So this is just a picture to show you of, what I've been unpacking. And CRE is much more global than we give it credit for, or than they gave it credit for at the time. Now, to speak a little bit about another carbapenem, NDM. So I will explain what this means, but again, just to illustrate the point of travel history, and it doesn't have to be cross oceans. The Swedish patient, when MBL or NDM, which is a type of MBL enzyme, was first reported, it was from a Swedish patient who was hospitalized in New Delhi. And thereafter, NDM was found throughout India, Pakistan, and the UK. So several UK organ transplant patients with NDM1 actually received transplants in the Indian subcontinent. So reports of NDM, again, just like APC, is basically everywhere in the world right now. Now, I'm going to take you on a different tangent to understand why we spoke about outbreak potential and propensity for dissemination, or how does this happen? How do bacteria develop resistance and become CRE? Do they prey? Well, we know they prey on us. I'll tell you what science tells us. So we need to appreciate, and it's very important to appreciate CRE, the vertical evolution of resistance or genetic transfer, and horizontal evolution. Now, what is gene expression? So you just have to take my word for it. I have brown skin. I could probably park in disabled parking without my glasses. That's how poor my eyesight is, and my mom is the same. So that's genetic. Oh, and I'm good looking. So those are genetic traits that can be expressed through genes. Analogy in bacteria. So vertical evolution, bacteria divide, and it's not like in humans where you have a 50% chance of acquiring the genome of your mom or dad. It's 100% with bacteria. So could you imagine if a parent cell has a CRE gene in its genome, all the daughter cells are going to be CRE. And then horizontal evolution. When bacteria are in close proximity to one another, there are these phenomena that it doesn't happen in humans. However, there's something called transformation and conjugation. Basically, they can exchange genetic material. And I'm sure you remember this from medical school or your science. But I want us to revisit it because especially important is plasmid transfer. So this is the picture that's illustrating it. And this contributes to the efficacy of CRE as a pathogen to cross borders and to cross species, because a Klebsiella can give a plasmid to a Serratia. Serratias are intrinsically resistant to many of our antibiotics we use when we don't have carbapenems, like colistin. Klebs can give it to E. coli. E. coli can give it to other strains of E. coli. So this gives CRE a lot of virulence in terms of widespread capacity for widespread. So moving on. So I'm sure we're all familiar with how antibiotics resistance occurs. When we expose the bugs to antimicrobials, they may mutate. However, we may acquire bugs through contact, the gram-negatives, the Enterobacteriales. If we're in a hospital setting, if we touch a doorknob, if temperature gets taken, a stethoscope is put on us, and if it wasn't cleaned, for example, that can be integrated and you may become colonized with it. So what happens then? You get an infection, you're treated, and what's eliminated are the susceptible bugs, and what proliferates or remains is the CRE or other resistant bugs. And if you need an IV line insertion, you need some surgery, disease can progress from there. Now, I want to tell you all of how genetic expression ties in with the phenotype. Okay, this is a bacterial cell, and again, I'm sure you may remember some of this from pharmacology. So in order for an antibiotic to work, it has to enter the cell, right? It has to bind to a specific site and then hopefully kill the bacteria. And I want to give you some outlandish examples that are deliberately so you never forget them and you appreciate CRE more. What is the most important mechanism that makes CRE what it is? So here we have a club in the UK. I have not been there, but if anyone wants to sponsor my ticket, not that I'm much of a clubber, but you have bouncers outside clubs, right? You shall not pass. So if the bacteria cell was a club and it had bouncers, those would be efflux pumps. They can pump antibiotics out. Then, this is for my Harry Potter fans out there. Or even if you just looked at a wall in the room you're in now, imagine it opening to admit you into a whole new world. Essentially, that's what an antibiotic is doing when it is entering a bacterial cell. However, bacteria can close their walls. They can seal their what's called pores, and we call it porin loss. And so they may prevent the admission of antibiotics into them altogether. And then, of course, there's that lock and key analogy that is self-explanatory. But now this is the crux when it comes to CRE. If this is a gun of a bacteria, you can bet that they're going to shoot silver bullets, which is the carbapenems. They are the magic bullets of bacteria that hydrolyze the carbapenems. And so, in a nutshell, those genetic mutations, the KPC, the NDM, are contributing to various silver bullets that are going to inactivate various antibiotics, namely the carbapenems and beyond. So there you go. So now I hope you will look at your reports in a different light. You will understand it's an Enterobacterialis. You will understand how it got to acquire the resistance mechanism to show you that R or the S that you see or the I. And it may harbor a porin loss or an efflux pump or what we're very worried about with CRE or the CPEs, which I'll explain, are the enzymes. One thing to remember and take note of is that while the carbapenems often go above and beyond, yes, they're overachievers and they will hydrolyze more than just the carbapenems, other penicillins, other agents like the piperacillin, tazobactam. We need to understand that resistance mechanisms to other antibiotics also are carried on those same plasmids. And by the time they are transferred, you have a whole host of antimicrobial resistance mechanisms. So for example, we could lose cotrimoxazole, we could lose quinolones, and it's not the CRE that's doing that. It's not the carbapenems, it's other resistance mechanisms that are on that plasmid too. Okay. So the definition of a CRE is members of the Enterobacterialis that are resistant to one or more carbapenem antibiotics or producing a carbapenemase enzyme. We must just remember there is a family within the Enterobacterialis. Those are your Proteus, Providencia, Morganella. They are more resistant or to imipenem. And so in those isolated cases, you need a carbapenem other than imipenem to foot the bill of the definition I've given you. So CRE in general, it's divided into your non-CPE and your CPE. Your CPEs are the ones that are producing the silver bullets, the enzymes. And ITSA says that 35 to 83%, very broad range, are CPEs in the US. So the non-CPEs, they become CRE by virtue of a combination of other mechanisms. Okay. So now let's talk about the carbapenems or the silver bullets. There are 5 main carbapenems. Okay, we like to think of them as the big 5. So what's important locally are the OXO48s and the NDMs. KPC accounts for over 80% of the CREs in the States. And every area will have their own epidemiology. And this is very important for the treatment because some drugs, especially the novel agents, you need to take extreme cognizance of the enzyme being produced so that you don't use the incorrect drugs when you're treating. And, further add to, stewardship dilemmas. So it's by virtue of amino acid homology that we classify them as such into these categories. I think just a few important points. So KPC, it doesn't have to just be Klebsiella to be a KPC. They can occur in other species. NDMs, they are more unpredictable and complex in their pattern of spread than KPCs. And OXO48s, which are very predominant here, there are actually more than 6 groups with more than 100 variants of the enzyme. And they have their own various capacities for carbapenems or carbapenem hydrolysis. I'm just sharing this with you so you appreciate that it's more than just a R or a S on your report, or just it's this enzyme. It can be very nuanced, and so I urge you to consult us and to learn more yourself. So this is a lovely article that I'm going to use as well to take us forward with some more practical advice and tips. So onto more of the clinical aspect. So where is CRE? It's everywhere. It's ubiquitous. Low and middle income countries have it tougher because IPC practices, although we have more resources in private, in state, it can be really hard. And, in my time at Tigerberg, especially when there were incumbents from Germany or the Netherlands, because, South Africa is beautiful and in that medicine is so diverse and different here because of our twin epidemics of HIV and TB and the trauma that we see. Everyone wants to come learn from us. But it was interesting to me that their rates in their ICUs, in their units, were so exceptionally low. And that is the testament to the most important tool we have against CRE, and that is its prevention. It's the IPC practices where the secret sauce is. So long-term healthcare facilities, step-down facilities, very high rates, Is this because of overlapping risk factors or other significant patient-patient transmission factors? That's, I think, the jury is out there. There are various studies that will comment on that, but I want to give you basics here. High antibiotic pressure units, so ICUs, high care, hem-onc units. So this is where you treat one patient, you are affecting the whole bacterial ecology of your unit. Just remember that. So who is at risk? Okay, so antibiotics, that's a huge predisposing factor. Cephalosporins, carbapenem use, some would say in the last 2 months, but it's important to get that history. Past CP infection or colonization, recent travel to high prevalence countries or facilities, long-term healthcare facility residents, and then we have now your CRE. They are fickle. They like fake things. Indwelling catheters, urinary catheters, feeding tube, mechanical ventilation. They also used to be very much associated with poor functional status, your more debilitated, severely ill patients, immunocompromised, patients with more comorbidities, and that's associated with higher antibiotic consumption. However, things are changing, and it surprised me in my research for presenting to you that the Crackle-2 study from 2022, and US does have better surveillance, reported a 10% of community acquired CRE, which is very worrying. And it may be a bit overestimated, as some patients tend not to report previous healthcare exposures, but I think that's worth paying attention to. We don't want to get to that level. And being first world and with antibiotic pressure, I would say that they are perhaps a little bit ahead of us, maybe not so with the private sector. So clinical symptoms, what does CRE do? The infections are identical in nature to other bacterial infections of more susceptible profiles. They are site-dependent. The symptoms will be as per site: lower respiratory tract, urinary tract, bloodstream infection, intra-abdominal. So I think it's important to appreciate that colonization precedes infection. They are contact spread. They spread by infected bodily fluids, blood, urine, stool, wounds. As I mentioned, contact with infected surfaces, countertops, patients, doorknobs, wash basins, other medical equipment and devices. Even pets can be, contact with pets, the CDC describes, you can acquire CRE. So let's talk a little bit about the lab ID before we go into treatment. And as is the case for IPC and clinical treatment, so too is the laboratory diagnosis a challenge, especially in the resource-limited setting. And the treatment and effective control depends on an accurate and prompt laboratory diagnosis. Yes, there are rapid genotypic tools or methodologies at our disposal to identify the enzymes. There are also more cost-effective means like lateral flow assays. However, there's not a one tool fits all, as in the PCR screen will be specific for the enzymes that it's targeting. It's not going to pick everyone under the sun. Hence, it's important to know your epidemiology and what you should be testing for or picking up in your lab. So each method, I'm trying to say, has its shortfalls. And the lab has to be very certain of CRE validity, because that putting that result out there is going to have far-reaching implications for the patient, the unit, the hospital, IPC, and clinical response. And so it's a team effort, with us, with IPC, pharmacists, communication is key. So before we can even get, however, to the fancier tests of, genotypic identification of enzymes, yes, it is possible to do them directly on samples in some cases, but generally speaking, we receive your samples, we have to put them out onto agar plates, as you can see. We then have to incubate them for at least overnight duration, or, we process in real time, however, a good few hours before colony growth can be yielded. And those colonies are what we work from. So that does slow things a little bit. And just as babies were not just born, they took 9 months, it takes that time for the bacteria to grow. Not 9 months, fortunately. But once we have those colonies, we use, or most diagnostic labs, that is called a VITEC machine. It enables us to get our antimicrobial susceptibility. And it's usually from this point that we start investigating what enzymes are at play. So just to touch on something, therapeutic principles now. Treatment is to be individualized, and we need to also consider first, am I dealing with colonization? Do I have to treat? Did my sample, is my result speaking to a sterile site or not? Are there pus cells? Was it a good quality sample? We will give you as the lab as good as we get. We then have to consider if it's complicated infection, uncomplicated infection. If you take a common site like a UTI, for example, that would mean the difference of being able to get away with treatment, a single agent versus, something like, I will say, phosphomycin or an aminoglycoside versus having to use your bigger guns. So that's important. Source control is extremely important because if you have an uncontrolled source, it stands to reason you can give the correct antibiotic for the correct time and you'll still have problems. The enzyme is going to help us determine what antibiotic to use. There are novel agents. Combination therapy usually comes in when you're suspecting CRE. You don't really have grounds to whip out your big guns like your zavicefta or your novel beta-lactam, beta-lactamase inhibitors. And you want to make sure you have empiric cover, so you may then try a carbapenem plus an aminoglycoside or a quinolone in case you're dealing with CRE. And then you need to consider dose. The duration of treatment is no different from infections that are more susceptible in nature. It will be guided by, for example, approximately 5 to 7 days if it's a lower respiratory tract infection. But you must be guided by your septic markers and your clinical response. You must be monitoring also resistance can develop while on treatment. Now, we don't have that much time left, so I just want to speak to you about the drugs. So international guidelines, the ITSA guidelines, says that colistin is not recommended for CRE treatment. It is recommended, the only case that they advocated for is for uncomplicated CRE cystitis. So versus comparator agents, the mortality and toxicity is higher. There are questions about its clinical efficacy, safety, and stability, as well as ability to test for it for susceptibility in the laboratory. Colistin, so why is this so? Why don't we know as much about it? It is from the 1950s, essentially, the era of Marilyn Monroe and Elvis Presley. This is where we've come to, having to resort to such an ancient agent. Now, that being said, I'm not saying don't use it because, practically speaking, do we all have access to the more novel agents? Can our patients afford it? So, these are just things to consider. And, I can attest that in public practice, it is very much used. And so CLSI does not have a susceptibility breakpoint for colistin, but we do report it using European guidelines. And then there's the question of toxicity. You will have these slides, so I want to, in earnest, get to chat to you about the novel agents. So your beta-lactam, beta-lactamase inhibitors, like your ceftazidime avibactam, which I'm sure many of you have encountered by now, they showed improved clinical outcomes and less toxicity versus the older agents like your colistins and your aminoglycosides. However, I must say this data is US-based, and bear in mind that KPC is the predominant CRE carbapenems that they have over there, and we have more oxo-48 and NDM. So we cannot use meropenem avibactam or imipenem relibactam, which are other novel beta-lactam, beta-lactamase agents for our oxo-48s. Zavicefta is our drug of choice for that. It's licensed for use in over 3 years of age, adults and children for complicated intra-abdominal infections, as well as hospital-acquired pneumonia, VAPs, complicated UTIs, bloodstream infections. You must know that if you're suspecting mixed infections like intra-abdominal, where anaerobes are very predominant, we must add metronidazole to this if anti-anaerobic cover is needed. Ceftazidime avibactam plus aztreonam is needed if we are dealing with an NDM. An NDM or an NDM plus of oxo-48 infection, because aztreonam will take care of the ESBL that's often coexists, and NDMs are susceptible to aztreonam, and it's the other way around. The NDMs are susceptible to aztreonam, and the ceftazidime avibactam will cover the other resistance mechanisms also usually present. So as you can see, it's not one ring to rule them all, one ring to find them all, as per the Lord of the Rings. There are many different strategies we have to use to identify them in the lab. There's many different things to consider in what to pick for what type of enzyme. So just a quick note, a few minutes on IPC. The first requirement in a hospital that it should do no harm to the sick, right? However, as you can now appreciate, the hospital is very rich in bacteria. I often say if we could see bacteria, there'd be more heart attacks and strokes because they're just everywhere. And you never have to feel alone because you have as many bacteria in your body, your normal flora, than you do cells in your own body. Everything around a patient, please consider, is an extension of that patient. Okay? And bear in mind all of the IPC principles we've chatted about. And so here we go now with new knowledge, but also, I hope more awareness on the IPC front. One probably that's looked at or looked down upon is hand hygiene, but it's actually the cornerstone and the simplest, most cost-effective way to avoid a lot of trial and tribulation. So Florence Nightingale said, how little can be done in the spirit of fear. So IPC takes center stage. I want to empower the IPC practitioners on this call. I know we've urged them to join. We don't have to screen healthcare workers. There's no evidence of benefit. We do not have to screen clinical cases. Colonization, they will be colonized, will be part of the normal flora for a long time, maybe up to a year. Mass screening is controversial, depending on local epidemiology and resources, and in outbreak situations, of course. We do have to isolate and screen our contacts. That's important. So when you get your laboratory reports, please start with that. Try and cohort your patients. Keep your CRE patients together. So as I said, time is and effective IPC are critical to limit, because we have a limited therapeutic arsenal, paucity of new agents. It's a simple measures that are also going to reduce rates of your other context-spread MDROs, like your MRSA, your C. diff, carbapenem-resistant Acinetobacter, carbapenem-resistant Pseudomonas. Also, this may not always be easy to get your one-to-one nursing, your dedicated SATS monitor, or, temperature probe, or your, whatever you need for your individual patients. This is where the first word wins more. But certainly, I take my hat off to the efforts made here. In many of the IPC meetings I have the pleasure of joining, you are doing a fine job. So don't forget about the gown, the PPE, okay, the gown we like to wear versus the gown we want to wear. Don't forget the signage to make everyone aware about the contact precautions. As I said, strict compliance to this hand hygiene is the cornerstone of any IPC strategy. So environmental cleaning, yes, that contributes as well. Please declutter, disinfect, try and identify and remove possible sources, and take-home messages. So I've spoken about all of these things. So CRE, difficult to treat, paucity of agents, very big outbreak potential, can disseminate very quickly. Antimicrobial stewardship doesn't mean don't use antibiotics. It means use them. Use them when they're necessary, even the carbapenems, but use them properly. Use the right doses. Remove the invasive devices when you can. Achieve source control. We will try our best to give you early ID. Please liaise with us, consult us. Distinguish from colonization and infection and when you have to treat, and focus on your IPC. Yes, and again, treatment is enzyme and site specific. So yeah, this is a public health threat that requires the concerted response of healthcare professionals from various disciplines, pharmacists, microbiologists, IPC practitioners, and clinicians. And while we are now in the age of CRE, it's the new SBL, we don't want to be in the age of pan-drug resistance. So this is ESP E. coli asking, mirror, mirror on the wall, who is the most resistant of them all? Of course, it's CRE. And I thank you very much for listening. I acknowledge the professor that I learned a lot from at Tigerberg and the many sources I used to make this presentation, and this will be there for you